It is my joy and my pleasure to welcome Professor N. Shivashankar to this Facebook Live. Welcome, sir. Dr. N. Shivashankar is the former professor and head, Department of Speech Pathology and Audiology, and the former associate dean at NIMHANS, Bengaluru. Currently, he's the senior consultant at Apollo Hospital, Jayanagar, Bengaluru. Professor N. Shivashankar has a postdoctoral research in central auditory processing disorders from the University of Colorado, USA, for which he was awarded by the Rotary International Foundation, USA in 1988-89. He has contributed to research by developing several tests for central auditory processing disorders and also published international, national book chapters and monographs. There's much more to Sir's credit. I'm leaving it in the description box for you to read through.
Thank you, Chitra. Thanks for a nice introduction.
Thank you very much, sir, for accepting our invitation and willing to share your knowledge with all of us.
It's my pleasure.
So I'm going directly into the questions now. Yes. Could you please explain what is CAPD in a nutshell? We are aware that it's like an ocean, and we would like to hear from you in a nutshell.
Before we talk about what is CAPD, what is CAP? Then we go to what is CAPD. As Frank Musiek rightly says, that how ear talks to the brain and how the brain understands what the ear is telling. Or as Jack Katz says, what we do with what we hear, which means is a simplistic term that once a sound gets into the ear structures, auditory structures, how it's processed at various levels and with various dimensions, and then pass it on to the higher structures for its interpretation, and then acting on that, the responses that you get out of what you hear. So that the whole thing is auditory processing. But if you look at it, it is both top-down and bottom-up approach. So you need to have a good auditory structures to refine the auditory signals on its pathway, and then make it available to the brain structures for its interpretation. So it is more from the periphery to the central and the central to where you have a cognitive linguistic kind of a thing, which also contribute to the understanding of the auditory signals. So if the system is not efficient enough to process this information and then sends it on to the higher structure, where the higher structure probably misinterprets the signal, and then that leads to the kind of behavior that we would see in this population. So processing disorders basically is not able to process the signals, particularly in the background of noise. Background of either the speech babble or speech noise or any other noise for that matter, they are unable to concentrate or attend to the signals. Or sometimes, like for example, 17 and 70, they have issues in understanding whether it's 17 or 70. So they miss certain sounds there while interpreting it. So these are the issues, and these issues have to be tackled by all of us. So it's the inefficiency of the system and not the hearing loss. It is inefficient because despite having good hearing, they have problem in understanding the speech of others, right?
Yes.
So also, the speech is very dynamic in nature. The way I speak is different from the way you speak. Though we all are in the same geographical area, but still our speech patterns are different. They are different because of our own language that we have, that mother tongue, which influences the other languages. And we are now speaking in English. And you know that my Kannada language, the local language, will influence my English language too. So such variations that we have in our speech, the brain has to accommodate all that kind of variations for it to understand and respond. And that is the system efficiency, which is probably weakened in the children with these disorders.
Wonderful. So very well explained in a real nutshell. So there are a lot of myths that surround CAPD. Could you explain what are those myths and how it can be busted?
Well, the first myth would be, I think, people think it's a hearing loss. Majority of the even professionals do think the child is having hearing loss, or whether it's a medical professional or allied professionals. When the child is taken to them, they would say the child is having hearing loss. Other parents would say the child does not hear properly. They do not see the child does not listen to properly. They would always say the child does not hear. So the
Mm,
moment the word hearing comes, everybody looks on to the audiometric pattern. That maybe the threshold is not good. Maybe this could be conductive hearing loss. Maybe there's a sensory
mm,
hearing loss. So you go on, looking at those aspects. So branded as having some hearing impairment, it's a myth. It's not that these children do have very good hearing. Secondly, they are called dullards, backbenchers. They don't do well in the school. They're lazy. And they don't attend to the signal. They want to go away from the classroom situations. And particularly when they are told to do certain things, given instruction through the auditory system, they fail to complete those instructions. They, they are called as daydreamers, and they're bullied by the classroom. And ultimately, these children, they become dropouts probably sometimes. So
mm,
these are the myths around that these children are lazy. No, they are not lazy. And they also say he's not intelligent. No, they are intelligent. They can do a lot of other things which really surprises you, that they do such a good work. But then why they are not able to understand my speech? Particularly so when there is a background. But one on one, they are able to do many things and effective.
mm,
So
mm,
we need to understand we should not call them as dullards or intellectually not good enough, and things like that. So probably we need to clear these myths that they are not dullards, they are not, they are intelligent enough, and the issue is with their auditory structure, which is not responding efficiently to the extent it should be done.
mm, mm. Beautiful stuff. And who are the professionals that would be working with these kids?
I think the host of professionals have to contribute to the development of these children. I would say, but first person is a speech and language pathologist. They would identify that child's problem. Like, for example, is it just the language disorder? Is it just the delayed speech in him? Is it just that there are issues with his attention, memory, and things like that? Then you would know that this child is not responding to the auditory signals, though you know that the child hearing is good. So then you would rope in the audiology people to look at it. What is the audiological issue that this child has? And so, speech language pathologists, audiologists, psychologists, they are also very important person. And the special educators, they are the educators, need not be special.
Mm,
The other
mm,
educators who are in the school, who are teaching their children, so they also
mm,
should be roped in to make
mm,
the life much more congenial for the child to learn. So these are the major professional people that I would rather look for. Well, other medical people, if required, can be sought. If
mm,
there are issues, like for example, these children, if they have childhood seizure disorders, which can also come in the way of
mm,
auditory processing. So such children have to be seen by neurologists so that they can give their opinion on that. And sometimes the children who become so hyperactive in nature and they don't see it and they don't understand and they don't pay attention, um, are taken to child psychiatrists and child psychologists. So probably, if required, we may have to rope in them to give their opinion about the child's functioning. So these are the professional people, I think, who would be involved in rehabilitating or giving the program, the remedial program for these children.
Hmm. So you spoke about children with seizure disorder who also can be present with the CAPD, central auditory processing disorders. What about other comorbid conditions that you've seen?
Yeah, like for example, as I mentioned, attention deficit disorder, autism spectrum disorder,
Hmm.
learning
Hmm.
disability,
Hmm.
all this population do have a problem in auditory processing. But
Hmm.
we need to delineate this properly. Like, for
Hmm.
example, auditory neuropathy is also a condition where they have problem in understanding speech. So we should be able to differentiate that what is the which kind of a problem these people have, and then
Hmm.
you might get a clear group of people without these issues, clear group of
Hmm.
children who have primarily processing disorders.
Hmm.
So first of all, we need to evaluate them properly to find out what exactly is the problem in these children. Like the
Hmm.
audiologist should be able to give us, because a mild hearing impairment or
Hmm.
chronic otitis media children, or maybe children with some high risk factors during birth, and these
Hmm.
are the issues also have to be taken. Uh,
Hmm. Hmm.
so that is the most important. I always say, Chitra, that record the history properly.
Hmm.
Everything should be recorded so well so that you would know that from the history itself, that you will be able to probably make a kind of a diagnosis, a provisional diagnosis, that this child may be falling into this kind of a group.
Hmm. Hmm.
If not done, for example, a 6 year child, a sixth standard child, I mean, sorry, sixth standard child, not able to follow instructions in the school, not able to follow instructions at home, and taken to a person, a doctor, and then say the child is not hearing properly. And one of the case that I'm mentioning here, and was diagnosed to have otosclerosis, and later then they did the stapedectomy at the age of 16, and then you finally, when they come to us, when the girl came to us, we found it is just an auditory neuropathy disorder.
Hmm.
Similarly, one of the child, the boy of a 10-year-old, but the doctor was so good enough, the ENT doctor, he said, go to the audiologist, get their verdict.
Hmm.
I'm not going to see your child, because to me it's something different. So go to them and get it. So when we evaluated, we said it's not the hearing loss. The child has auditory processing disorders. It was
Hmm.
not auditory neuropathy. It was a clear case of auditory processing disorders. So there are many instances like this. So understanding the behavior of the child, like in the
Hmm.
case of Landau-Kleffner syndrome, it can also have central auditory processing disorder. It can be a
Hmm.
comorbid condition in them. So
Hmm.
these comorbidities have to be looked into properly in depth. And after all that is over, and if you don't see anything else, and if you see only the auditory processing itself, probably you can get a very clear group, homogeneous group to tackle with. However, whatever may be, whether the child has comorbid with auditory processing, no comorbid auditory processing, all of them have to be treated for improving their auditory processing. And speech and language training program is an essential part of any kind of processing that we talk about. Ultimately,
Hmm.
the child has to read, the child has to write, the child has to communicate properly. And that is where we all come in. So it is not just the sound per se, it is
Hmm.
also the language per se that we are looking at it. How the child
Hmm.
is able to make the interpretation. And when you look at the remedial procedures, you get a lot of things about these things. So we need to understand the comorbid conditions, many of them.
Yes, yes. So with that said, for a private practice sector like ours, how do we go about identifying and providing interventions?
Well, private practitioners, it all depends on the kind of setup that you have. For example, um, in a private practice, first thing I always say, documentation. Second one is behavioral observation. And you have a questionnaire to assess the skills of central auditory processing, which is available in our country. One is developed by Dr. Asha Etiraj, can also be used. And one which we also did it in way back in 88, modifying Willeford test battery, behavioral assessment scale. So those scales can be used to check for auditory processing disorders. And then later, if you have the infrastructure to do, you can use some of the central auditory tests. Now, I have to be very cautious in this aspect, because when we talk about central auditory behavioral test, which has a lot of language in it, whether you take a dichotic sentence or digits or computing sentence or whatever, filtered speech, all of them have an equal amount of language load. And secondly, also has a lot of attentional factors to that. So each language is different, and you can't have a test done in each language. At least whatever is available, we should be using it. Along with, to an extent, whatever is possible, use the electrophysiological measures also to understand the central auditory processing. And some of the non-speech tests, like for example, duration pattern or the pitch pattern or the gaps in noise test, are very efficient tests to look at the auditory processing, as well as the test that I have to mention to you. And generally use a lot of dichotic digit test, not even the dichotic word test, because most of us are very much familiar with the digits, at least 1 to 10. And therefore, but each one of us should have a good normative data to compare with. The other important thing, that at what age that you have got the child. If you get the child around 4 years and 5 years and then say the child is not listening properly, it's very difficult to do any kind of behavioral test with these advanced tests I'm talking about.
Yes.
The Pluton audiometry you can establish, which probably shows normal. So we need to wait for some time. You know that myelination process is a process which goes up to the age of 12, 13 years, when the corpus callosum gets matured and the interactive between the hemispheres, they all come to a kind of a maturation level by the age of 12, 13. So whatever that you find the deficits on a central test, can we say that this child is having central auditory processing disorder, or should we wait for till 12, 13 years of age and then say, oh, this child has central auditory processing disorder? What I would do the test even at 7 years of age or 8 years of age with whatever normative data which we have, and then start up with a program. These programs will enhance the learning capacity. It is not going to deteriorate the learning capacity. And therefore, you can use, even with many of the normal children, some of the things that we use, like dropping techniques, like, in the sense, supposing I remove the word from mat from doormat, what is left? And the child should be able to think, okay, remove the mat and then say it's door. So these some of the things that, even we play with normal children. And I do play with my own granddaughter, and she enjoys doing that. And sometimes you also use non-speech tasks like clapping, and clapping with different rhythms. Okay, so she knows that how the pattern is coming. So whether 2, 1 and 1 separate, or 1 and 2, or 2 and 2, that kind of a thing. So the child will enjoy that and try to attend to the signal. What is important is to build the auditory attention. For example, some of the techniques that you can also use, while testing whatever that abilities that the infrastructure that you have, you can even say that whenever you hear the ta sound, you just raise the finger. Okay, so you can start with the just sounds like ta, say da 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 da. It's like P300. You do that P300 there and find out what is P300. And instead of that, then you can use it here to make the child to attend to the signal. And similarly, then you can go on to a word level, that whenever you hear the sound in a word, you raise that finger. Like for example, water, the child has to, right? Pour, the child need not. And milk, the child need not. But butter, the child has to show. So that kind of an attention, you can build it up at a sentential level. So these are some of the cancellation technique, I call it as, because the psychologists call it as a visual cancellation technique. So it's not a kind of thing. So many of these things can be utilized in the private practice. Not necessarily you should have a high funda kind of a thing. If you are able to generate some of these tasks for the children, you should be able to identify them.
Very informative, sir.
The most important aspect that you ask the mother, parents, when they say the child doesn't hear well, I would always say, is it hearing or listening? Then they would say, but when I call him, he doesn't respond sometimes. Particularly when I call him when there are people talking, he doesn't respond. So he doesn't hear. He didn't listen to you. Do you know it's the hearing problem or the listening problem? Then I would tell them, supposing they are, let's say, English speaker. And if I tell them that, Dashina, Dishukushitashi, Dishukushinashi, Shutu, and they would say, what is that you are talking? And I would say, I don't know what I talked. I just said some sounds. Then I said, did you listen to it or did you hear it? You heard it. You also listened to that. You heard it and listened to it, and you found out it is something not sensible. Then you ignored it. Which part of the body, the whole thing, we ignored it. Your brain ignored it. So that you need to listen to, and for listening, there are certain prerequisites which has to be there. Now, if a child has a problem in the background of noise, so you need to remove the noise so that child can understand your speech better. So some of these things, can be utilized. I don't know. I'm mixing up your many questions probably.
No, not at all, sir. It's very, very informative, and I'm getting so much of information from you, and I'm actually excited to hear all of this.
See, as I told you, and when I'm talking to you, sometimes in my mind, I feel that I'm talking too fast, and I try to control my speed. When I start controlling my speed, am I just controlling the speed of utterances, or am I also changing the prosodic feature of the speech? This is very essential. When we say slow down your speech, then they slow it down and bring it at a flat level. That's not the way it should be slowed down. You need to hold on to the prosody of that sentence and then slow it down for the child to understand. This is how we speak with foreigners. We want them to understand, and therefore we slow down our pace of speech. Right? So with these children, probably you need to slow down a little bit so that they are able to process it properly. Longer sentences should not be made. As much as possible, utter shorter sentences, so that the child will be able to formulate some information. You are reducing the information load on the sentences, so that give information one after the other, and simplify the process, because the child should be able to synthesize the information ultimately and sequence the information. So when we are teaching something, now listen to me. Point number one, this. Okay. Point number two is this. So if you say 1, 2, 3, 4 and give that information, the child will be able to assimilate that information. Instead of paragraphing the whole thing, it will be very difficult for the child to do that. See, the children are the best teachers for us. They will let you know how to speak with them. And if we can translate that and transfer that technique to the parents and the teachers, I think we are making the child's life much more happier.
Yes, absolutely, sir. I actually was about to ask you what are some of the strategies that clinicians can and parents can use. And I think you've already answered that.
There are many more. There are many more. There are auditory strategies, environmental strategies, communication strategies. So first in the environmental strategies, home environment versus school environment. Now, basically environment is reducing the background noise. Now, seating, preferential seating in the classroom situations, and making the teachers to understand that this child is not a bad child. This child is not a dullard. You need to give more instruction, so more visual input to the child while teaching. And while asking questions, make it into a smaller, shorter sentence form. Only one word answers to be elicited, so that the confidence of the child will grow up. And as you walk through the walkway, you just put your hand on the shoulder of the child so that you bring the attention to the classroom situation. Because of the dryness of the speech, in the sense, if I talk to you for hours together, you don't feel like listening to. So in the classroom, it happens to the child too. So just to bring the attention, put your hand on the shoulder and walk, and you don't have to do anything with the child. So that brings the child's daydreaming, kind of a thing to the real situation and be alert on that. So also if you have FM systems and things like that can be used, but some of these strategies are helpful with slowing down the speech, right? And at home also try to avoid as much as possible the noisy environment, like putting on the TV and instructing the child, making certain noises in the kitchen and instructing that child will be difficult for the child to comprehend. And therefore, you got to modify the environment to the extent possible. As I told you, some of things like communication strategies is face-to-face conversation. Maybe some of the visual things can be also shown while you're communicating to the child, so the child can understand it very well. And say, for example, I want to go to ask father to get me 17 rupees. That is 70 rupees or 17 rupees. So then you would say, no, tell your father that mommy wants 17 rupees. So you get so that the child will be able to modify your utterances. Very simple to say that, right? So simply modify the utterances and always engage the child in a much more interactive manner. And secondly, it should be a pleasure for the child to interact. If it is a painful to interact, none of us would interact. Communication should give happiness. If communication doesn't give happiness, then why should we communicate to each other?
Yes.
It is true that you are passing on information, but while so, it has to be given in a proper manner. Probably modify it and through a very positive approach, which can be done. So you have environmental communication, and auditory kind of a thing. If you want to, you can create a lot of auditory strategies for the child. As I mentioned to you, one thing is that dropping that word in the in the paired word kind of a thing, or it could be I will spell it out and you give me the word. Like for example, the word is book. Let's say no, it's B O O K. It's not B O O K. You can modify that and see how the child behaves there. So when the child is able to hold on to the information and then say the word book, so you can probably try on those things. Or you can also have some kind of a speech background and then tell the child, listen to my speech. Forget about what is happening in the background. Which can be done in private practice. You just have a recorded speech and just play it off. Suppose you have a recorded speech in Kannada, some student. Okay. Then this child is both Kannada and English child who can perform. So now then you would say, okay, now just forget about what that person is talking about. Let me see. Let me give you some numbers, digits. Just repeat those digits in English. Now, if that recorded speech is a female speaker, and if you give the signal in a male voice, that digit, it's easy for the child because there are different, the figure ground. Right? So then the child say the 5, 1, 8, 2, 34, in the background of female Kannada speaker narrating something. And then go on to your word level in English. And then go on to a Kannada word in English. Your competition between the background and the foreground has to be graded one. So you can have that competing kind of a situation where you can train the child. Or minimal pair distinction, same versus different. Like like bill, whether the same are different, or bill with the same are different. So you can have that kind of word strategies, for a child. Or maybe you can have a lot of pictures and then probably give something which is to one picture and the rest of the things are similar in nature. So you can develop a lot of strategies of these things to train the child, whether it's a private practitioner level or at the home level. These things can be translated.
Wonderful. So it was so enriching for me to hear you. And there's so much information you've shared. It's like literally a 1-hour course kind of a thing where starting from understanding CAPD to the myths surrounding it to how to assess and treat in a private practice. It was a very fantastic and an informative session, and I thoroughly enjoyed it. Thank you so much, sir.
Thank you, dear. I don't know whether I have covered whatever you wanted to do today, but hopefully some things we have covered. Maybe sometime in future we can have a probably much more discussion on this.
Sure, sir. We thoroughly enjoyed it. Thank you very much for your time and all the information that you've shared with us.
Thank you so much for inviting me, dear.